Okay. Okay, thank you very much, Chris. What I'm going to do is just take a minute to go over the learning objectives. I want to make sure everybody is at the right webinar and on the same page with what we're going to be discussing. First, I'll provide a very brief overview about fetal alcohol spectrum disorders, FASD, and then we're going to jump right into talking about women who are at risk for having an alcohol-exposed pregnancy and what some of the evidence-based prevention strategies are that you can utilize in working with women. And then we're probably going to spend, I would say, that maybe the first half or a little bit more on that, probably a little bit more prevention, just because that's where I'm coming from professionally in the prevention field. And then we're going to talk a little bit about FASD and what do we mean by secondary disabilities, what are the protective risk factors, and what are some of our strategies and interventions for helping those who have a diagnosis of FAS or somewhere along the spectrum for FASD. And then in closing, I'll be talking about some of the resources available to you, primarily the websites that can take you to various agencies and organizations that can help you, whether you're in the prevention or treatment field, whether you're a professional or perhaps some of you may even be parents or caregivers for individuals with FASD. Throughout the program, I will try to reference resources as they come up, but we'll do a little synopsis towards the end. As Chris said, I'm very happy to take questions every so often. Chris, feel free to prompt me, because sometimes I'm not the best at remembering. And also, I do want to say that if I don't have the answer, I will get back to you soon, and I will make myself available for follow-up questions by email as well. Okay, first we're going to start with a little poll, because we like to be a little interactive as we can. So Chris, do you want to continue with the poll?
Sure. Okay, I'm going to launch the first poll now, and just click your answer. Margo Singer did another webinar on FASD back on February 1st, and we'd like to know whether you actually participated and attended that previous to this one. Okay, we have about 61% right now. We'll wait another few seconds or so to get a better response rate.
This is a pretty easy question, so hopefully we could do it quickly.
Yes. Okay, let's see. We have like 70% responded, and 33% said yes, they did attend, and 68% did not.
Okay.
We have about 2/3 new viewers.
Great. Okay. Well, I actually was going to apologize if I repeat any information, but since most of you weren't on the webinar, I don't think I have to worry about that. And those of you that, the 33%, you can just listen. It'll be a quick refresher. So first of all, why are we here talking about fetal alcohol spectrum disorders? What is this we need to prevent? This is 100% preventable when women do not drink alcohol throughout their pregnancy. And the national statistics indicate probably I think it's about 41,000 babies are born every year with an FASD. So clearly we need to do more with our prevention efforts. We're not reaching people because this is 100% preventable. There are other public health issues of concern to pregnant women, but a lot of that is not 100% preventable. I mean, you could still take vitamins and nutritional supplements, things like folic acid, but those things aren't 100% preventable. But with alcohol consumption, if a woman does not drink, her baby will not be born with this birth defect. It is the leading known cause of preventable mental retardation. This is not a term we still use. We like to use intellectual disabilities, but this is really where the research has come in from in terms of preventable mental retardation. Again, there's other issues such as autism. We don't really know perhaps what the origins for that is, the genetics, the environmental factors. But with FASD, again, it is preventable if women do not drink alcohol. The annual costs in this country, and we all concerned about healthcare costs and costs of society, over $6 billion a year. And again, this probably is an underestimate. And again, what we're going to be talking about later on, the secondary disabilities that can develop if FASD is unaddressed or undiagnosed, the issues such as increased risk for mental health, criminal justice involvement, dropouts from school, addiction, unemployment. These are the kinds of things that we're going to be dealing with if we don't address FASD. Okay, so since many of you weren't on the first webinar, I'm going to give you a little overview. This is a diagnostic term. This is not a diagnostic term. This is a purely descriptive term. It came about probably back in 2004. A group of clinicians and experts, researchers, caregivers, people from different fields of psychiatry, criminal justice, mental health, they all got together to decide on this term because up until then we've been talking about fetal alcohol syndrome, FAS, and fetal alcohol effect, FAE. And it was felt that we were missing a lot of individuals if we didn't understand that this is really a spectrum disorder. So depending on when the mom drinks during pregnancy and other maternal and genetic factors, an individual can be born with very severe effects or very, severe or moderate effects. So really is more of a spectrum disorder such as what we understand autism to be. This is a plural term. For some reason, Canada uses a singular term, but it's meant to say the same thing. Now, on this slide, you're going to see some other things there floating around under the umbrella. And these are other terms that are part of the spectrum. So PFAS is partial FAS, ARND is alcohol-related neurological damage, ARBD, alcohol-related birth defects. So you'll still see these other terms in use, especially if you do any research in the area. So we'll start with some facts. No amount of alcohol consumed during pregnancy is proven to be safe. Wait, I think I bumped ahead a slide. Hold on a second. I've got some issue with my computer. All right. You know what? It's not letting me go back to another slide, and I will just go over it on the notes, but for some reason, slide number 6 is not clicking in. Just some statistics here. It is a lifelong disorder. This is not something that an individual grows out of at any particular age. It's a permanent, lifelong disability. Right now, the national statistics, FASD is estimated to affect 10 in every 1,000 babies, or we like to think of it as 1 in 100. So again, that would be over 41 babies born every year in this country. But there is a widespread, difference even among those statistics. So FAS, which is the diagnosis part of the spectrum, would be probably 1 in 1,000. We don't have very good prevalence numbers in the United States. Our data collection is very limited, and even here in New York, where we have a CDC-funded surveillance grant right now, that is for Western New York, so it's not even for the full state. And they do have some other projects funded around the country, but it's not going on in every state. So the data collection methods vary, again, by study, and we don't have any real active surveillance for FAS right now. So these are pretty much the statistics, and again, as we'll be talking about during this webinar, people with an FASD can improve and function well in life with proper support. So getting back to this slide, what's very important to understand is that no amount of alcohol consumed during the pregnancy can be considered to be safe. We understand that people metabolize alcohol differently. Men and women metabolize alcohol differently. And we really don't know at what amount of alcohol is going to cause this birth defect. So what we need to let women know is that no amount of alcohol is safe, and again, at not any point in time during their pregnancy. And this really is a difficult message because a lot of doctors we're finding are still providing mixed messages, even though we've been working very closely here in New York with the American Congress of Obstetricians and Gynecologists. We find that there's still a lot of mixed information. Women are told, well, it's okay to have a drink now and then to relax, or, just don't drink during the third trimester because, everything is formed by then. There's still a lot of myth and misinformation out there. And again, a lot of it is because we can't do research, directly on pregnant women. This is all done in laboratory settings with mice and rats and other animals that have very similar gestational, situation. But we really don't know, how much alcohol can harm. So we need to be safe and let women know, no alcohol during the pregnancy. Now, we do know that this is not something that women do intentionally. Women do want to have healthy births. They want to have healthy pregnancies. But it's not like we turn blue when we become pregnant. Women often don't know that they're pregnant until weeks or even months after conception. And while they may be very well-intentioned about having a very safe pregnancy, they may have learned about proper prenatal care, but they just don't know that they're pregnant, and they may be continuing their risky behaviors. So we really need to start our education, in that preconceptual period. So even with women who we know might be trying to get pregnant, we need to make sure, that they are using either contraception to prevent the pregnancy, until they're ready, or else not be drinking if they are trying to get pregnant. We also know that women may not be aware of the harmful effects of alcohol. We found in a research project that we did for one of our federal grant applications, we did focus groups with women who were enrolled in our treatment programs, and we found out that there were all sorts of myths about what kind of alcohol to drink or not drink. For some reason, women felt that they were making a distinguishment between, drinks that were okay and drinks that were. So, for example, we heard from women, they said, oh, I only drank, wine. I didn't drink, the hard stuff, the tequila, the scotch, or the bourbon. Women said that their mothers told them it was okay to drink, clear liquid, clear alcohol, not colored alcohol. So they were making these differentiations. There's a lot of products out there such as wine coolers and Alco Pops and these kind of flavored alcohol beverages. And women may not be aware that they're containing alcohol no matter how they're packaged, and that could be very harmful for them if they're pregnant. So again, there is a lot of information out there that we need to help women learn about their alcohol consumption. And finally, we know that some women are unable to stop drinking, that they may have an addiction, an alcohol dependency, and they are going to need treatment and support. So these are some things that we need to keep in mind when you're working with women who are at risk. Okay, so what are the numbers? This is probably the most recent information that's taken from one of the CDC national surveys, and it's really conclusive in that the number of women who drink alcohol while pregnant really has not changed that much over time, and this was a result of a 15-year study. So here we're looking at 1 in 8 women drink alcohol during pregnancy. So it's something that we need to continue to focus our efforts on. Okay, so we've got another question. We're just zipping away with these poll questions. Make sure you're still awake. So Chris?
Okay, here, let me start the second one. Okay, here's the second poll. What is the definition of binge drinking for a woman? 3 drinks on one occasion, 4 drinks on one occasion, 5 drinks on one occasion, or 10 drinks on one occasion?
And for occasion, we're looking at probably like a 2-hour setting.
Okay. Wow, we're getting a lot of response on this one. Let's see. It looks like it's at 83% response rate now. The 43% say that 3 drinks on one occasion is binge drinking. So that's 43%. 45% say 4 drinks. And 9% say 5 drinks, and 2% say 10 drinks.
Okay.
So it's, let me close this and then so they can see the responses. So it's pretty even between 3 and 4 drinks.
Okay, thank you, Chris. And those of you who said 4 drinks, 45% is correct. And this is according to the National Institute on Alcoholism and Alcohol Abuse. And this would be 4 or more drinks for a woman, and for men, this would be 5 or more drinks. The CDC recently actually did a webcast, I think it was about a month ago, on binge drinking, and they did say it's the most common pattern of excessive drinking. So basically 90% of excessive drinkers binge drink. And in fact, the binge drinking increases with household income, and also the frequency increases with age. And I think I've got some statistics here. They're not on your slide, but in terms of like that childbearing age, 18 to 24, 25.6% of people binge drink, and ages 25 to 34, 22.5%. Now this is of all adults, and we did use some statistics for the numbers of women who were binge drinkers of childbearing years when we did our federal grant. And we did find that in New York it was pretty much higher than the national average. And don't have those numbers in front of me because it's quite a couple years old. But you know, the reason we're talking about binge drinking is that it's especially harmful pattern of alcohol use for a woman who is pregnant. So basically what we're looking at are studies, and again, they're done with mice and rats because it would be unethical for us to give pregnant women alcohol. But the studies have shown that binge drinking is much more harmful than an ongoing drinking of like a lower quantity. So when the mother consumes alcohol, the baby's blood alcohol reaches levels as high or higher than the mother's. So it's basically what we're looking at here is consuming, you know, a large amount of alcohol in a very short period of time. And that is more harmful to the developing fetus. And as I said before, all alcohol beverages are harmful. So, you know, regardless of whether we're talking about beer, light beer, wine, liquor, you know, spritzers, wine coolers, even those, you know, non-alcoholic beers, you know, have some level of alcohol in there. Now, not every alcohol-exposed pregnancy will, you know, have an outcome of FASD, but again, there's no way to predict. In fact, there was a very interesting study that was done by Children's Research Triangle. It was Dr. Ira Chasnoff, who's an expert in a lot of prenatal addiction issues. He was working with a woman who was pregnant and gave birth to twins. She drank during her pregnancy. One of her twins came out perfectly fine, and the other twin showed the effects of the prenatal alcohol exposure. So, you know, we really don't know you know, how to predict this, but we need to know that even light alcohol use can affect the developing fetus through pregnancy. And there really is no safe time or safe amount. And again, this goes back to the fact that each person absorbs and metabolizes alcohol differently. And they're still doing a lot of research right now on identifying those genes, the aspects of the genes that can increase or decrease the effect of a given amount of alcohol on the fetus. So this is an area of emerging research, you know, the effects of alcohol with respect to certain genes. So the next slide again reinforces this whole point that a lot of different factors are in place. Also maternal age. I believe the research is showing that with older women, their children and who are drinking during pregnancies, their children have worse symptoms of prenatal alcohol exposure. Certainly there are other important things to take into account in terms of maternal nutrition and health status. So for instance, if a woman is using alcohol, it may impede the effects of the vitamins and the nutritional supplements that she's taking for her pregnancy. But it's important to remember that there is no safe time, no safe amount. I'm going to go on to just a few more slides here, then we'll take a break for questions. Chris, I haven't forgotten. Now, why do pregnant women drink alcohol? I think it's really important to keep this in mind when you are working with women, to really know about some of these risk factors for alcohol use during pregnancy, which are actually very similar to some of the risk factors for smoking during pregnancy. First of all, at the outset, before I go over this slide, I do want to say that women are very relational in their behavior, their drinking behavior. What this means is that women are very strongly influenced by either their spouse or their partner and other family members who are around them. So like let's say a woman is trying to stop, but her husband wants her to go pick up, the beer at the store and then to drink with her, drink with him. It's going to be much harder for her to stop. And let's say, there's some family pressure to go out and celebrate something or other. She's going to be very influenced by those others who are very close to her. So as I said before, many women are simply unaware that they're pregnant. I believe the statistics say that 40 to 50% of all pregnancies in this country are unplanned. So again, you might have someone that's been educated about this and wants to have a healthy pregnancy, but simply was unaware, that she's pregnant and is continuing to drink. The second reason is the social norm. This actually goes pretty closely with the third bullet there. It's common when celebrating festive seasons or special events. Just trying to think of, recent holidays. Certainly in the Albany area, we always have a big deal around St. Patrick's Day. And in fact, there's been, some news reports about, very uncool behavior of the college kids last year. Well, the year before this past St. Patrick's Day, which I think unfortunately earned them some very negative press. But what we know is that it's the social norm. I mean, you see all the advertisements for champagne on Valentine's Day, the Super Bowl, the beer commercials, probably right around Memorial Day when it's, prime barbecue season. We're going to start seeing a lot more alcohol advertisements as well. So if you're a woman that's over the age of 21 in this country, it's perfectly legal, and it's something that's marketed very strongly to, having good times and celebrating, weddings or anything else. Another reason is that women often say that they know other women, even their own family members, who drank during pregnancy and who have children who appear to be healthy. But again, in many ways, FASD is an invisible disability, and it's not something you're really going to observe when you see somebody straight out. So, are these children really healthy? I mean, you might find out, well, perhaps they're struggling in school, with math and with science, or perhaps they're having behavioral problems. So do you really know that these kids are okay? But unfortunately, a lot of women are very influenced, again, by others. So if they say, well, my sister drank during her pregnancy, her kids are okay, or, my mother drank with me. I mean, these are very, hard things to really turn people's minds around. So that's something you need to keep in the context. Women may not know how much alcohol harm can be caused. So again, women may not be understanding of the amount of alcohol they're drinking. We find when we do the alcohol screening, which I'll be talking about, it is very important to ask them how much they're drinking. Because for them, a woman, let's say, who has an alcohol dependency, if you ask her how much beer do you drink, she might say one, but that one beer could be, 64 ounce or if you say, you know, how many drinks did you have when you went out with your girlfriends last night? They say, well, I only had one Long Island iced tea. Well, that one Long Island iced tea has about 3 or 4 shots of alcohol in it. So that's not exactly what we consider one drink. So you really need to be very specific, and they don't realize that something like an alcohol pop, where it's kind of a wine spritzer or, you know, a wine cooler, does have alcohol that could be harmful for the developing fetus. And the last 2 bullets, again, these really are looking at women who may have an alcohol dependency or alcohol use problem. They may be coping with difficult life situations and using the alcohol to self-medicate, again, struggling with an addiction. And chances are these women are going to need a lot more than education. They're going to need treatment help. They're going to need, you know, resources, probably from, you know, a community-based treatment program. So, you know, these are folks that do need to get the information, but they're probably going to need something more. Another thing that I did want to point out, that drinking behavior during pregnancy is very closely related to drinking behavior before pregnancy. And there's been a number of studies on this. So a lot of that is important when you're doing an assessment, you know, of women if they're coming into your office. And we'll be talking more about screening for alcohol use in a minute. So why don't I'll just see, Chris, if you have any questions at this point.
Okay, yeah, we have a couple here, and then I also have somebody who wants me to unmute them so they can ask a question. And Mia, let's see if we can hear you.
Sure. Can you hear me?
It's very, very faint. Are you using a computer microphone?
Yes.
I don't think others who can't adjust their volume will be able to hear you. So why don't go down and open up that audio box, and then switch to the telephone and dial in. And in the meantime, I'll go to this other question.
Okay.
Okay. Yeah, that seems to happen with computer microphones. And unless you have a really good computer mic, it's better to just use that toll-free number and dial in if you want to ask a question. Okay, now here's one that we have a question on. Is anybody studying the impact of marijuana use during pregnancy?
Okay. Yes, in fact, there are studies pretty much on every substance of abuse in pregnancy. So you've got, you know, studies on opiates as well. I would say that marijuana in pregnancy is not an area that's been quite as researched as some of the other areas. And I don't have any specific information really to address on marijuana, but I do want to say that one of the reasons that we do present on alcohol specifically is that it's pretty much recognized that alcohol is a teratogen, and that's a substance that interferes with the normal development of a fetus, is the most commonly used teratogen by pregnant women. But what it is, it has the most severe neurobehavioral effects of any other substances of abuse, including, you know, marijuana and cocaine. So you all know that I work for the Office of Alcoholism and Substance Abuse Services, so I'm not, you know, advocating that it's okay for your clients or people that you're working with to use marijuana or other drugs during pregnancy, but we need to understand that the research has shown that unlike alcohol, the effects of those other drugs used, you know, prenatally over time can almost be ameliorated. So, for instance, the research that was done with the babies born during the crack cocaine epidemic, their mothers used cocaine prenatally. With early intervention and other appropriate developmental supports, a lot of those kids kind of caught up to their peers. And I'm not saying that the kids were perfect, but a lot of the learning delays, you know, they were dealt with very successfully. So alcohol is a very different beast. It targets the developing brain, and there's other physical health conditions associated with this, but this is pretty much permanent brain damage. So alcohol is very different than the effects of marijuana, for instance. Now, just to conclude, that we do have a information on our OASIS website. If you Google the Addiction Medicine series, part of the addiction medicine part of our website, there is a workbook that talks about treating the pregnant, addicted women, and that one actually doesn't focus as much on alcohol, so it does talk about marijuana and the other substances of abuse.
Yeah, that's great. I can send them a link after this webinar. Mia is on the phone now, so Mia?
Yes. Hi, and this may be premature because I know you were going to cover this later. I just wanted to know more about what services are available to kids with FASD. How, I know there's a kind of a screen form that I don't know how much it's actually used, and how kids are identified. That probably would be the first question, and then what kind of services are available.
Okay. Hi, Mia. We're pretty much going to talk about that in the second half, but okay. There's really, just to let you know as a heads up, there aren't a lot of tailored, targeted services for FASD, FAS specifically in New York. So it's more like what the symptoms of the individual might have. So again, after they've been assessed and screened. So for instance, and again, depending on the age as well. So if they're a very young child, for instance, and there's a speech delay, then they would be referred to early intervention, again, if they're under 3 years of age. And in terms of, so that's just one example. So you're basically looking at the different behavioral issues. So, if they need some sort of, tutoring for math and science, there are remediation programs that focus in on that. But there's not a lot of programs here in New York, and I'll talk about screening a little later, and remind me in case I forget.
Okay, thanks. Okay. I'm going to ask you again now, Mia. And there's one more question here. Do you have the name of the study regarding the use of crack cocaine during pregnancy, because this person is seeing long-term effects on a child?
I can look that for you. I think it's basically a cohort of studies because there were many, many studies done on these children. So I think it's just reference in the literature. But yes, I can definitely get you a citation. So
okay, yeah, that'll be fine. And I can distribute that after, after the webinar. So,
okay.
So I think that takes care of it.
Okay. Very good questions. Okay, so pregnancy is a very highly motivating time to work with women. As I said, women do want to have a healthy baby. They may know some information, but they don't know all the pieces of the puzzle. One of the federal research projects working with pregnant teens found that after giving them information on FASD, most of them either quit their drinking or at least reduced their drinks. But again, education alone is not enough. And prevention really starts with asking. I know that some of you that have signed up on the webinar are from the healthcare arena, in addition to, working, those of you who are working directly in treatment. But we need to understand that this is a very sensitive issue, and often there is a need for confidentiality, for real language check on how you're asking your questions. It's very sensitive because one of the barriers for women is they are worried about, if they have children already, they may be at risk for losing their children to Child Protective Services if they disclose alcohol and or drug use. Some of them might be at risk for losing benefits that are available to them. So there's a lot of sensitivity to this issue. And in fact, I was talking to someone the other day who works in one of the WIC programs. They find that they're not getting a lot of responses when they ask because one of the things is that they don't have a rapport established. So we talk very specifically about, when you do the screening and how often you should do it. So for instance, you might not get a very good result if you ask the first time a person comes in to see you. It may be that they need to really have a trusting relationship with you and a little rapport with you to disclose this information. So it may be something that you're going to have to ask at every medical appointment. One of the things that we're going to talk about is universal screening. So it would be certainly wonderful if everybody was asked these questions, and so the stigma around being asked this would kind of go away because people would realize, oh, everybody's being asked these questions. So we need to understand that the question, it's not just how you ask the question, but also the frequency. So in terms of asking the questions, we're going to talk about screening tools in a minute, but you can embed your questions when you're asking about other things. So for instance, you could have a whole survey that's asking them about a number of things, wearing seatbelts, using suntan lotion, smoking, and then embed the questions in there so you don't feel like they're being targeted for this information. And we're going to talk much more about screening. So this section of the webinar, we're going to talk about some of the evidence-based prevention initiatives that have been funded by the Center of Excellence, which is part of the Substance Abuse Mental Health Services Administration. And they provided 4-year grants they're actually a little over 4 years, but in 2008, 15 prevention and intervention initiatives were funded across the country. There are 3 different models. The PCAP model, which stands for Parent-Child Assistance Program, which is different from a Department of Health program here in New York. They funded 2 programs. We're not really going to be discussing them because these are basically home visiting model programs using women in recovery as kind of peer mentors. And anybody wants to email me the information. There is a website that's been set up to have that information. But we're instead going to focus on project choices and screening and brief intervention, which is also called SBI. These are programs that more talk about screening and working with women in a variety of different settings. Some of these are actually WIC programs, which I mentioned, which is the Women, Infant, and Children Nutrition and Health Program. They actually can be done in criminal justice settings. They can be done in jails. They can be done in EDs, emergency departments of hospitals, as well as on school campuses, college campuses, and obviously in substance abuse treatment settings. This is a national program. I'm actually going to skip to 17 because I just wanted to talk about this for a second. Project Choices is the first evidence-based model I wanted to talk to you about. Funding was awarded to our agency, as I said, in 2008. And we're one of 6 projects. There are projects in California, Texas, Wisconsin, and Mississippi. And we're one of 2 states that are managing the project. So we have a statewide initiative. And we are working with outpatient and residential treatment programs. This is meant to be an integrated initiative within the treatment program. It's not meant to be a standalone program. So what Project Choices is it's a 4-session counseling intervention, and it uses motivational interviewing as its platform. And in addition to the 4 sessions, there is a visit to a contraceptive provider. So what we're looking at here is working with women who are at risk for an alcohol-exposed pregnancy by addressing 2 behaviors, the risky alcohol use as well as ineffective contraceptive use. And this really was a perfect project for us because we really believe that women, even though they can go through treatment successfully, there's always the risk of relapse. So we know that it's not always possible a woman is going to stop drinking, but we do know if we can give her the tools to make good choices about her contraceptive use, then if she's using effective contraception and she does have a relapse and is drinking, at least she won't be at risk for an alcohol-exposed pregnancy. So I'm just going to flip back to the last slide. There we go. Sorry to confuse you. So this intervention, the eligibility requirements for this program, as we were doing it with our federal funding, is that this would be offered to women of childbearing age between the ages of 18 and 44. This was defined for us by the federal agency that funded us. The women have a screening form that indicates that they are drinking at risk levels. They are heterosexually active. They're not pregnant, but they're able to conceive. And also it's a voluntary program, so it's not something that they have to undergo. It is an option. And these are the different service settings. We are doing it, as I said, in residential and outpatient substance abuse treatment programs. We're actually winding down our project, and so we don't have the final data, but here is some data that, this is from the national projects. In 2003 was when, and this was funded by the Centers for Disease Control, the CDC, and they found that they reduced the risk of an alcohol-exposed pregnancy among 68.5 participants, and that was only after a 6-month follow-up. And then these other statistics, basically in 2011, last year, that has shown that this intervention has been effective not only in reducing binge drinking, but also in increasing abstinence among women in residential treatment, as well as community settings, or what we call outpatient programs, at both 6 and 12-month follow-ups and at the end of the program. We're still having our data come in. I wasn't able to crunch it for today's webinar, but what we've learned so far is that we are showing the same reductions in drinking, increased abstinence, and increase in effective contraception. So that's the other piece of it. Some of the data is hard to collect because the women are still in treatment. So for instance, if they're enrolled in residential treatment, they're not supposed to be drinking at all, so you think that the rates would be good on that. But they are able sometimes to have passes out into the community, and they are showing that they are using effective contraception when they're engaging in sexual activity. So our programs right now that we're doing this with are funded in Western New York and outside of the Buffalo area, in Cheektowaga. We also have programs that are funded here in the Capital District in Albany, New York, as well as down in the city, in Queens, in the Bronx, and in Long Island. So we're very hopeful that after the project is over in May and we have some good data to show, that we will be able to introduce this into other programs funded by our agency. So as I said, this is a project that's based on motivational interviewing and the stages of change. And we find that this is a method that works very well with women particularly. It's not very confrontational. It is not counselor-oriented, so that means it's not the counselor telling the client what to do, but really trying to ascertain, the ambivalence of the woman. What are her reasons? What does she enjoy? What does she like about drinking? What are the reasons for her not using contraception? And all of this is explored, in basically 4 different sessions, as well as the contraceptive counseling session. And that session is really to teach her about different methods that might be more appropriate and more effective for her as an individual. If she chooses not to have the contraceptive device, that's fine too. But it is an educational session. There is a workbook. Everything is kind of scripted out for the counselor. There are different exercises that are used. So for instance, they might talk to the woman around her interest perhaps in, let's say they maybe walk her through how many drinks she drinks on every occasion that she drinks, on a daily basis, a weekly basis, a monthly basis, a yearly basis. Usually the women are pretty amazed at how much they're drinking and also how much they're spending, because there's a formula to crunch out. And that may be a motivating factor for her when she realizes that she probably put enough money into drinking that she could have bought herself a new car. So there's various different tips and techniques, again, using motivational interviewing techniques, decision balance wheels, a readiness ruler. Motivational interviewing in itself is a whole different training, which we do offer. It's usually a 12-hour, 2-day training. But some of the basic things to understand about motivational interviewing is that we know that persuasion really, as a tactic, and education alone really isn't going to be enough to help people change very habitual behaviors. So we need a counseling style that's, very motivational in approach to really increase a woman's readiness to consider change. So we really need to change some of those traditional addiction counseling techniques, such as those employed often by therapeutic communities. It's very confrontational, like you must do this. Those aren't going to be effective for women. We do know that here is some research from Dr. Velasquez, who is one of the initial project investigators for Project Choices, and she had found that approaches that incorporate these elements, giving her positive feedback, making encouraging statements, highlighting her ability to make choices, being very direct and straightforward and non-judgmental, the use of open-ended questions, which is a hallmark of MI, providing accurate information, again, dispelling a lot of the myths around alcohol use, expressing empathy, building self-efficacy, again, eliciting the woman's ideas to make change and determining her readiness to do so, using small steps, avoiding blame, presenting a whole range of options, removing barriers to change. These are the kinds of things that work well with addicted women, and these are the cornerstones of the Project Choices curriculum. Now, the Project Choices curriculum has just been released by the CDC. There is a facilitator's manual. There is also a workbook for counselors and also a journal for clients. And we do have these on the OASIS web pages. So at the end, when I talk about resources, you'll be able to go to our Project Choices section of our website and download these materials. And again, they can be used in a variety of settings. One of the things that we know about motivational interviewing, it's been used in a variety of ways, whether it's, to reduce tobacco use, for weight loss. It's been used in a variety of, public health concerns. Dr. Velasquez, really stresses that it's our approach that is going to be key. We really need to engage women in such a way that's really going to drive the intervention. So again, a lot of it comes down to how you ask the questions and not being, judgmental, but having a more empathetic style is really going to result. You don't say, you don't drink, do you? If you have a pregnant woman in front of you. You talk more engaging with an open-ended, how many drinks do you drink? We know that women drink. It's certainly legal and promoted in our society. Can you tell me about, your drinking behavior? You ask it a much more empathetic and open-ended questions. And again, you're giving women options and avoiding blame. That's really key because, as I said before, there's a lot of barriers for women coming into treatment, and some of it is the guilt and the shame, the fear of being judged, but also, real-life fear of losing their children. So here we go. When women are asked about the kinds of approaches that have been the most effective, a supportive, non-stigmatizing relationship is among the most helpful and effective. So again, that relationship between the provider and the patient can be a very big predictor of successful outcome. And it's also very important to examine your own strengths and potential biases. You know, we know in our society that we all carry a lot of, you know, we don't maybe realize it, but there is a lot of stigma and bias around women's use of alcohol, especially pregnant women and mothers. You know, there's a lot of, you know, shame and blaming going on. And again, you know, women drink, you know, they may be ignorant. As I said, they may not understand the harm that alcohol can cause. So it's very important that we examine our own personal biases, you know, to make sure that we're not, you know, bringing along any of these things that could potentially affect our relationship with the women that we're trying to help. Okay, so I think we're here for another poll question. Chris?
Okay, get this one out. Okay, this poll is about screening. What is the screening tool for alcohol use among women? The TACE, the audit, the tweak, the cage, or all of the above? So please enter either one or all of the above. And while people are doing that, so we don't have any dead air here, we might as well get a question in.
Okay.
Are there any studies related to alcohol use in fathers contributing to FASD?
Okay, that's an excellent question. Basically, it's important to understand that FASD is caused solely by maternal alcohol consumption. This is a point I usually stress when I do my overview, and I do apologize for not bringing it up. When I did these slides, I was thinking that most people had signed up for the first one, and this was part 2. So this is something that I do go into quite a bit, and it's always great when there are men in our trainings, because even though this is only caused by maternal alcohol consumption, there are things that we need, you know, the men to be aware of, and to be aware of men's drinking. So, you know, as I said, this is only when alcohol crosses the placenta to the developing fetus that we have this birth defect called FASD. However, if a man is drinking during conception, we do know that there is a genetic disposition to alcoholism. Again, this is where the genes are involved. So it would not be the birth defect of FAS, but we do know that chronic alcohol use, there is a definite disposition for the next generation for alcoholism. We do know that chronic alcohol use by men can cause infertility in the sperm. I did discuss how men's use of alcohol can be very much a factor in why a woman might continue drinking. You know, if her husband wants her to drink along with her or is drinking around her, it's going to be harder for her to stop. We do know that the research shows that alcohol and substance use by either parent, the mother or the factor, can be a risk factor for the child having alcohol or substance abuse problems later in life. You may have heard the term children of alcoholics or children of substance abusers, because there is a risk for them. Certainly, if a person is engaged in active alcohol or substance abuse, it's going to affect their child rearing and their nurturing, their parenting practices potentially. So again, these are all things that we need to make sure that men are educated about as well. But the bottom line is it's only the maternal use of alcohol that causes FASD.
Now to go over the poll, I'm going to share those answers. There was 77% of the attendees responded. 8% say the case, 2% say the audit, are for the tweak, 22% say that the gauge is the screening tool for alcohol use among women, and 66% say all of the above.
Okay, thank you, Chris. Okay, well, 66% of you passed the test. It's true, all of those are screening tools for alcohol use for women. And I did find it interesting that 22% of you did say the cage, and I think it just may be that the cage has been around the longest. It is the most familiar, I think, to a lot of people. These other tools were developed, over the last maybe, 10 or 15 years. However, the cage is actually the one tool that we don't use quite as much because it was designed for women, but it really hasn't been validated for use for pregnant women. So, I don't even actually have it on this slide because these are the tools that we really want to encourage your use, with pregnant women. And in fact, some of the cage sometimes is criticized that it might even not be as valid for women as it might be for men or just the general population. So what we're looking at are the TAs and the tweak. They were both specifically designed for use with pregnant women. They've been shown to be very valuable in identifying women who are using alcohol during pregnancy. The TAs has 4 questions. The tweak has 5. Both of them are available for you to use. They're in the public domain. The CDC, I think, has a really good publication, which is on our website, that does include the full instruments. Can be downloaded. The SMAST, the short Michigan Alcohol Screening Test, the audit, and actually the audit there's a shorter audit, which I believe the audit is 10 questions, and the audit C are 3. There's also something called the 4 Ps, the 5 Ps, developed by Dr. Chasnup. I think there's a 4 Ps plus. The 5 Ps, which is the Institute for Health Research in Massachusetts. Those are often very good. I think the 5 Ps, the 5th question there, deals with domestic violence. But if you Google these, you'll find a lot of good information. So what we're looking at here basically are effective screening tools that can be answered, asked and answered in really a matter of minutes, and also scored in a matter of minutes. The next slide gives you an example of the TA screening tool. So you see it's only 4 questions. The T stands for tolerance, A, annoyed, C is for cut down, and E is for eye opener. So everything is scored by points. A positive would be 2 points or more. But again, if you're working with a woman who's pregnant, any answer, any drinking, you're going to want to provide more education and intervention. And the next slide, actually, what you would want to do is perhaps combine the TAs with some frequency and quantity questions. And this has come from the NIAAA. So again, you're asking them in a typical week, how many drinks do you have that contain alcohol? And then the next is kind of a binge drinking question. You've had more than 3 drinks on any one occasion. Now, I have the words drink in quotes here because, again, it's very important to ask women and men, too, when you're screening them, what kind of drinks they have. I don't have a slide for it here, but I can make that available to you. There is a standard drink chart that basically shows by illustration of an actual drink, whether it's wine, beer, hard liquor, spirits, cocktails, how much alcohol is in a drink because, as I said, a Long Island iced tea, it's 1 drink, but it really is, it's a binge drink when you think about it. So you really need to be able to have that chart in front of you when you're talking to them about screening for alcohol use. So we're now getting into the section about screening and brief interventions, which is the second evidence-based program, again, that was funded by the FASD Center for Excellence, and there's a lot of information NIAAA has on it, and also ACOG, which is the American Congress of Obstetricians and Gynecologists, are all on board with it too. So basically what we're talking about, the screening, which I think you understand what that is, asking people about their alcohol use. And then the second part is a brief intervention. So we're really talking about a very short encounter that provides information and can be very effective in changing their behavior. So let's talk about what SBI is. So here we have, again, the criteria would be for the women, if they've taken the TACE or the tweak and they've self-reported certain drinking scores, then they would be given an intervention, which might be a 10 or 15-minute session. Usually there's some sort of workbook that goes along with it. This chart talks about some outcome studies that were done in 2007. They were comparing participants that were in a brief intervention and assessment-only groups. Women were 5 times more likely to report abstinence after the intervention compared with those that were only in an assessment group. So again, the women who got the screening and the intervention were more likely to be abstinent than those that just got an assessment. Newborns and mothers who received the brief intervention had higher birth weights and birth lengths, lower mortality than those women who just were only assessed. And the client outcomes from this FASD Center funded initiative again shows higher abstinence reports at the 3rd trimester for those clients that did receive the screening and the brief intervention. This is another part of their project that is showing data. This actually is an intervention that it's not necessarily only the woman who gets the intervention, but the spouse, the baby's father, the client's mother, really any other family member or friend who's identified as a significant support person for the pregnant women actually was able to get the intervention. And this, it says this was done at the WIC settings and also Healthy Families, which is a home visitation program. Now, as I said, this is from a national project. We don't actually have this particular program here in New York in terms of this particular setting. We do have screening and brief intervention, but this again was funded through the FASD Center for Excellence. So again, they're showing that the interventions were enhanced. This was very interesting that when the support partner participated, and again, this is someone of their choosing, the effects of the intervention were higher. So, this is something very positive because we do know that, as I said before, women are very relational. So if you have somebody who's going to kind of enroll with them, and agree to the intervention, that's someone they're very influenced by, that this is also going to be very positive. Now, I mentioned ACOG, and again, ACOG is the American Congress of Obstetricians and Gynecologists. They, in New York, are having a CDC grant project that is funding them to promote universal screening and brief intervention. They are, in fact, encouraging their membership, which are OBGYNs, to use the TA screen, such as what I provided, along with those frequency and quantity questions. So what they're going to be doing this for are new patients and newly pregnant patients. So they're going to use the brief intervention plus the motivational interviewing skills. So right now they have a pilot. It started here in Albany, and there's going to be one in New York City, in the Bronx, and one in Buffalo. And these are all 3 different OBGYN sites. So one is very large. I think it's actually the one in Albany. One is very small, and one I think is a university-based practice. So what they have is an online toolkit, and this is the website, so you don't have to be an OBGYN. That's very interesting. They have a cell phone application for the OBGYNs to use. And the next couple of pages, actually I think it's just one or two, these are some of the tips that, again, they're encouraging their clinicians to use. So before they actually start talking with the women, these are things that they want the person to have. So for instance, have realistic expectations. If the woman you're dealing with has, been drinking or hungover, don't talk to her now. You wait till she comes back when she's sober to talk to her about these issues. Have your patient education materials ready. Have information about appropriate treatment referrals. Certainly practice the intervention. These are basic, common things that, you probably would use with any patient. But these are some really important things. This is a message of hope. We've talked with women in our treatment programs who have come in and they said, oh, woe is me, I already drank. When my husband and I found out we were pregnant, I was pregnant, and we celebrated, and we binge drink, whatever it was, the damage has been done. But actually what we know is if we can encourage a woman to stop at any point during her pregnancy, to stop her alcohol use, then that point on, her pregnancy will be alcohol-free and there'll be much better birth outcomes. So it's very important, really, to carry that message of hope. And one of the points I wanted to mention there is the bullet where it says, discuss drinking behavior in the third person. This goes back to the whole issue of social norm. When you say a lot of women find they find themselves in risky situations when they drink at this level, it's really not, kind of judging her, but letting her understand that, others may be in the same situation. Again, going back to the fact, alcohol, legal substance, heavily promoted. So you don't have to provide this information in a way that's going to be, maybe seen as potentially, threatening or negative to her. But just to let her know that, hey, you're not really all that different from other women that we see in this office, and this is something that we find that, we need to educate people on. They don't realize, that the risks that are involved. So it's very important at the end to leave her with written materials and to also talk about treatment options, because we find that some of these interventions with the screening and the brief intervention, the idea is really to get her into agreement for a plan. You don't have to get her to say, okay, I'm going to stop drinking, but really have her, sit down and find out, again, if she's pregnant or if she's not pregnant, but have her write up a plan that's realistic, that's something that she's going to agree to, and it's not just going to be kind of pie in the sky, but it may have some, very action-oriented steps. Who is going to be there to help her? Who is going to be there to support her? If she needs to go to treatment, how is she going to get to treatment? Does she need a ride? Does she need child care? Work through these things so that it's a very realistic action plan. Okay, Chris, I think we're going to do one more poll question. And keep these poll questions coming to make sure you guys are still awake and listening.
Yeah, this is the last one, and I'll take names, although I can't really. Have you heard of expert? That's either a yes or a no, so this is going to be a pretty easy one.
Are there any other questions at the moment?
Let me see. Well, there is a comment here, and I don't know where this person is from, but she says there are no specific services for FASD. Interventions and strategies need to be tailored to meet the child's needs, since many programs or interventions may not work for FASD. Case management typically falls to family members who know the child the best. It is extremely important that professionals work closely with the family member who knows the child the best.
Well, that's an excellent point, because not every individual with an FASD is going to look like any other individual. We're going to talk more about it, in the next section coming up. I promise to get to that very soon. But it's FASD is unlike other developmental disabilities that may present themselves, all one way with all one set of symptoms. And again, going back to when the mother drank during her pregnancy, the frequency, the dosage, the timing, and those other maternal and genetic factors, a child with FASD is going to be, at different places on the spectrum. So if you have somebody whose, core weaknesses might be more the behavioral issues as opposed to maybe executive functioning, yes, you're going to need very different, tailored interventions. So not what's going to work for one child or an adult with FASD is going to work for another child with FASD. So yes, that's an excellent comment. And I think in general, with any issue, I think that parents need to be listened to by the professionals because they do know their children the best. Okay, so do you have your poll results?
Yes. And let's see, 43 have heard of SBIRT and 57 have not.
Okay. Okay, great. Okay. And again, without knowing, the answers to this, I've just tried to do my best here with a little information on SBIRT. So it looks like most of you don't know about SBIRT. So SBIRT is screening, stands for screening, brief intervention, and referral to treatment. And while I don't say that it's specific to FASD, it is a evidence-based method that is effective at motivating individuals to change harmful substance abuse. So SBIRT is a method that healthcare practitioners, providers, and others, it's basically gives them the skills to discuss behavior changes with patients. So here we're talking about women who are at risk for an alcohol-exposed pregnancy. They may be pregnant or not pregnant. And we do have a whole SBIRT informational page on our website. And those of you who are in New York probably are going to be interested in the reimbursement available, and I have a link there for the web page, and so you can get more information on that. So basically, SBIRT is in 3 parts: the screening, and again, this is kind of identified by SAMHSA here, but this is really designed to screen and deliver early intervention and treatment services for persons with substance use disorders, as well as those who are at risk for developing disorders. It's been found to be effective not only for alcohol but for tobacco. And I think I read somewhere that the U.S. Preventive Task Force ranked it as, I think, the 3rd and the 4th most beneficial and cost-effective prevention service available among, I think, 25 they studied. So I think screening for alcohol and tobacco use actually ranked higher than other sorts of screening, like for blood pressure or cholesterol or colon, cervical cancer. I mean, it's right up there. It's been endorsed by the AMA and the Academy of Pediatrics, ACOG, ASAM, all the different national organizations. So basically what we're looking at are screening those individuals is a way to identify those who need, further assessment or treatment services. Okay, it's not making a. Basically, the goal is to screen as a routine part of medical care. So these are people that might be coming in, for instance, through the emergency department. It might be an elderly person who's fallen down 1,000,000 times, and then when you screen them, you find out that actually the problem is that they've been using alcohol and perhaps prescription drugs, and they need this basically brief intervention, which really is basically considered a single session or perhaps several small sessions using the motivational interviewing. And it really is building motivation through a collaborative conversation. And some of those may need referral to treatment. They may need something more extensive than the brief intervention. So again, the SBI, which we just talked about, doesn't have this referral to treatment piece, which basically links the patient with appropriate requested services. It is meant to be universal, so the idea is you're screening everybody, using an example, everybody coming into the emergency department. So you're not just screening, these people or those people, but you're screening everyone who's coming in. Again, you'd be using the similar screening tools that we talked about. You might also be using a pre-screen. The CRAFT is a screen that's used specifically for adolescents. So I think it's important to understand about SBIRT because it is something that is reimbursed right now in different healthcare settings, as well as done by certain professionals. Now, training is required in order to do it. I don't have time during this webinar. Typically, the SBIRT trainings are anywhere between 4 to 6 to 12 hours, depending on, what sort of background you may have been done. So right now, SBIRT's typically done most often in emergency departments, I would say primary care facilities and college health centers. Here in New York, we are trying to pilot SBIRT in adolescent school-based health clinics, which is great because here you may be working with young women who are sexually active. So we do have a pilot that's ongoing right now. I think it's just in the New York City area with a few school-based health clinics. Now the next slides, this is actually a guide. I just like the graphic. I probably could have stuck it in just about anywhere, but this is information on a clinician's guide helping patients who drink too much, which actually walks an individual through how to do the screening and the brief intervention. They have a little pocket guide that's condensed, and here you have your step-by-step. So it's way too small to read here on this slide. But you're doing the screening, assessing for alcohol use, and then you're providing the information. Oh, here's the information I was looking for. This has the standard drink and some information also on medications as well. So now we're going to get to the FAS part. I did spend a little bit more time probably on prevention. As I said, that's my own professional background. So realizing that many of you did not take the introductory webinar, I'm going to go quickly on FAS. Now remember, FAS is part of the spectrum, FASD. This is the diagnosable part of the spectrum. This is in the ICD. So I'm going to talk more now on dealing with individuals who have FAS and what are some of the strategies and solutions. So according to the CDC, there are 4 criteria for identifying an individual with FAS. We have growth deficiency in height or weight, or both, either prenatally or postnatally. We have specific differences in facial characteristics. This is the palpebral fissures, which are the short eye slits, a smooth or indistinct philtrum, and that's the ridge that's between, vertically running between your nose and your lips, and also a thin upper lip. So those are 3 facial characteristics that must be in place. The 4th component is damage to the central nervous system, and this can be demonstrated functionally, neurologically, or structurally. Again, this includes things like microcephaly, which is the small size of the brain. It can include things like tremors, hyperactivity, issues with fine or gross motor problems, attention deficits, learning disabilities, intellectual impairments. And then the last is evidence of the birth mother consuming alcohol during pregnancy. This is especially problematic, or, well, I wouldn't say problematic, but it's especially tricky because a number of individuals with FAS are coming through child welfare or through foster care or through international or domestic adoptions, where often we don't have the information on the birth mother. However, the CDC does allow for suspected non-confirmed evidence. So if you know the mother perhaps had a DUI or was incarcerated or a homelessness or, seen by someone drinking, that, some of that would be allowed. Now, not everybody likes to make the diagnosis without confirmed evidence, and you might have some people that really do require that. Now, I do need you to understand that if you don't have all 4 of these components, again, you may fall along the spectrum. You might have, remember at the beginning I talked about ARND or ARBD or PFAS, so you might not have the actual diagnosis of FAS, but you still could be on the spectrum. So let's see. I thought I had a poll question coming up, but I think it's coming up soon. So facial characteristics. Again, this is what I was referring to before. We have the short palpebral fissures, the indistinct philtrum, and the thin upper lip. Frankly, I don't like spending a lot of time talking about the face because we really, if we think about just those individuals with the facial characteristics, you know, as I said, FAS is 1 in 1,000. FAS is 1 in 100. You know, it's much more common. FAS is what they call the tip of the iceberg. You know, it's only just a very small part. And I'm fearful that if we concentrate just on those individuals with these facial characteristics, we're going to miss providing appropriate services and supports for so many other children. And the other thing we have to recognize is that people do grow out of their facial features. And so a lot of people who make the diagnosis, you know, they're not going to want, what we find here in New York and in other places around the country is that there is a reluctance to diagnose people who are, you know, young adults, adolescents, because they have grown out of their facial features. So what instead I'd like to concentrate on are really those information processing problems. What we need to understand is that those who are affected by prenatal alcohol exposure, they have difficulties due to the brain damage. And those are the things we really need to be focusing on. These individuals have problem taking in input, taking in information, interpreting new information with things that they learned previously. They have issues with output, the ability to use the information appropriately. So what we have is, you know, executive functioning issues related to abstract reasoning, cause and effect reasoning, generalization, issues with time, memory, behavior. A lot of abstract reasoning, we don't realize that in a way abstract concepts are almost like the foundation to our world, you know, but for individuals that have this brain damage caused by the prenatal alcohol exposure, they're really going to have a difficult time. So the IQs may be very average or even high. It's really quite across the board, as I said before, depending on when the mom drank during her pregnancy, what was developing with respect to the central nervous system. You know, individuals are going to have different, you know, neurobehavioral profiles. It's going to be very individual to what was developing in their brains at the time the mother was drinking alcohol. And issues such as verbal, receptive language skills, a lot of these individuals, you know, they may be probably, I would say, half their age in developmental supports, not developmental supports, that's not what I wanted to say. For instance, they may present like at age 18 but have the social skills of a 9-year-old or the comprehension skills of a 9-year-old. They may really present at about half of their actual developmental age. Pretty much, except in the verbal skills, they're very, can be very verbal. There are other co-occurring issues. Mental health is probably at the top. And then you have a lot of co-occurring not only substance abuse, but you can have ADHD, you could have attachment reactive disorder, OCD, a lot of other co-occurring mental health issues, I would say primarily. I'm running along quickly because now I'm seeing that I'm running out of time. We do have a poll question, but Chris, I think in the brevity of time, I think we're going to skip this because I really wanted to get a sense if you knew about making a diagnosis, who can make the diagnosis. So we're going to skip that question and let you know that basically the approach here is a medical multidisciplinary team. So ideally we would want a number of trained professionals. A core team could look like this with a physician, psychologist, neuropsychologist, speech and language pathologist, occupational therapist, and social worker. So if you don't have all the team together, you may have to get referred for other tests. There are a number of instruments used. I know that Mia had asked about screening tools. There are some screening tools that we're looking at for possible use here in New York, doing a pilot down in Westchester County as a start. The screening tools often take into account very different emotional, behavior, intellectual issues. And again, some of them are age specific, so you might ask a younger child very different questions than you might ask an older individual. But what's very key is to do a very thorough assessment and keep a record of all behavioral, physical, medical issues and copies of all reports. It's not uncommon for the person who's making the diagnosis to ask for photos of the individual at different ages. And again, depending on the person's age, the person might be seen by, for instance, a developmental pediatrician. That might be done, within a pediatrics office or within an FAS clinic or a genetics clinic. Here in the state of New York, this is an area we have many gaps, and very common it is for us to make referrals to Dr. Luther Robinson, who is with the Women and Children's Hospital Special Diagnostics Clinic in Buffalo. He is able to do a thorough FAS diagnosis, and I do know that he will work with adults. Unfortunately, we don't have diagnostic capacity in every region of the state. I know that there are several viewers on this webinar who are from different states. So for instance, our neighbors to the south in New Jersey have a regional diagnostics setup so that they do have centers around the state. And we know that's true in Alaska, state of Washington, but unfortunately here it can be a very patchwork of getting services for our families. We do have a list on the OASIS website of existing resources for our diagnosis as we know of them. As we get more information from families and professionals, we try to add them to our website. We do have a state-funded, through the Department of Health, genetics program in which there are genetic specialists, again, in different parts of the state. So we do encourage a diagnostic team, but it's not often available in every community. Clearly, there are many benefits for early and accurate diagnosis, and in fact, early diagnosis is one of the protective factors against those secondary disabilities that we're going to talk about. With the diagnosis, we really can help people focus on their strengths and what will help them succeed instead of just, their weaknesses. We can also prevent future births of children with an FASD. And this is very important because, as I said before, there may be some women who think that their children might have, behavioral issues. It's just genetics because the grandparents are like this, and everybody in my family's got a mean streak, or compulsive. But it really may not be that at all. It may be the fact that they were drinking during their pregnancy. We do know from research that women at highest risk of giving birth to a child with FASD are those who have already given birth to a child with FASD. So it's very important to identify these children and to provide support and treatment to their mothers. We also know that the benefits of a diagnosis is important during any stage of life. It really can help reduce a lot of frustration for caregivers and parents and help them better recognize and manage the issues and again obtain services throughout their life. And we do know that a diagnosis is important at any time in an individual's life. So some steps to take after a diagnosis. again, we need to explain to the individual that, their brain works differently. Frankly, all of our brains work differently. I think my brain is working a little differently right now because I've been talking a long time. But we need to understand those results from the diagnosis. You need to share them. So perhaps if your child is of school age, that they need to be shared with the school to get perhaps a IEP, individualized education program or plan that could provide services such perhaps as speech therapy. There may be some disability services. Here in New York, we do have a system through our state office of persons with developmental disabilities. Unfortunately, a lot of those services are IQ-based, and many oftentimes individuals with an average or high IQ, even though they have tremendous difficulties in adaptive living and other functional areas, they may not qualify for services. And again, you're going to want to share this information with your child's or individual's pediatrician and other healthcare providers to help obtain appropriate medical support and services. So let me run quickly here. I did mention at the beginning that we have something called secondary disabilities, and these are really the result of living with the struggles of a primary disability. So again, the impact of these conditions can be reduced when parents, caregivers, professionals, and others really understand the challenges that these individuals face. So this was a study that was done by Anne Streisguth. She really is kind of the guru of FASD, FAS. She's written a number of books. She had a clinic at the University of Washington in Seattle at the time when FAS was first diagnosed by Drs. Jones and Smith in 1973. And so her study was done over a 15-year period. And she had children, children and adults, I believe they ranged in age from about 6 to, I think, 51 or in their 50s. And basically, her study showed the high correlation of developmental secondary disabilities, including mental health problems, disrupted school experience, trouble with the law, confinement, inappropriate sexual behavior, alcohol and drug problems, dependent living, and problems with employment. And this was really across the board. Actually, this was a study of individuals that had either FAS or FAE, because again, this was done before the term FAS came into being in 2004. So unfortunately, these are the secondary disabilities that can occur. However, we do know that there are protective factors, and this was, again, a result of her study. So while we can't, cure, per se, FASD, it is a lifelong disability, and a diagnosis of it in itself can't be changed. There are ways in which we can work with individuals to help them reach their full potential. So for instance, stable home. What we're looking at here is a loving and nurturing stable home environment. Children with an FASD, and again individuals, because this is a lifetime disorder, so either children or adults, with FASD can be more sensitive than other children to disruptions, changes in lifestyles or routines, and harmful relationships. So it's very important to have a loving, stable home life for a child. It's apparently, with respect to foster care, there are a number of moves permitted. So that is kind of unfortunate because it goes against this, that we really need to have a consistent living situation. I think the average, they said, of more than 3 years in each place. And again, we're talking about, a really good quality home as well. Not being frequent changes of homes. Let's see, not being a victim of abuse, neglect, or violence. Again, this is a protective factor for co-occurring issues, especially sexual inappropriate behavior. In the study that was done, nearly 3/4 had experienced some sort of violence, whether it was physical, sexual, or domestic violence against themselves. Children with FASD need to be taught other ways of showing their anger or frustration and not become involved with youth violence. And the last two I kind of saved because they're really, really, really important in terms of how we can get help. One is receiving developmental disability services and things like early intervention, special education, and social services. We know that early intervention works with children from birth to 36 months to help children talk, walk, interact with others. So as I said before, there may not be a specific FAS treatment program that you could send someone, but if they have problems such as speech delay, speech therapy can be provided by early intervention absent a formal diagnosis. So if an individual is unable to get the diagnosis of FAS, they still perhaps could receive these services. Here in New York, we have a program through the health department in every county of the state. I don't have the information here to give to you, but you can email me later. There is a toll-free number which you can contact to find out about early intervention services. And then the last thing is diagnosis before the age 6. We have found that early and accurate diagnosis is really essential. And in the study, the persons with FAS actually had better outcomes than those with FAE. So it goes to show that probably the earlier and specific diagnosis probably helped individuals obtain services that they needed. And again, early diagnosis can help the families as well as the school staff and others that interact with the children, why the children might act or react differently, from other children that they're working with. So I'm moving right along. Sensory integration is an area in which we have kind of taken some of the skills and techniques that have been used with the autism spectrum disorder to help individuals with FASD. Sensory processing disorder is the inability to process information received through our senses for generating appropriate responses. And the result of this is a decreased ability to respond to sensory information in order to behave in a meaningful and consistent way. It can also lead to difficulty using sensory information to plan and organize our own bodies and really be meaningful in our environment and how we function, and really impact on our skills and our ability to learn. Just running through this very quickly, okay? So what we're looking at is the brain can be not functioning accurately to process information coming in from our senses. And individuals with FASD may have an oversensitivity to some sensations, perhaps overreacting to touch or movement, or even loss of balance. They may be undersensitive to some sensations. They might need to crash or to bang into walls or sharp sounds to register things or flavors. So sensory integration problems, basically what we're talking about here, affecting our 5 traditional senses, especially touch and hearing, but also taste, sight, and smell. So what we're looking at here is the way in which the body responds. So for instance, persons with an FASD might have sensory integrations making them over or understimulated. They may flinch at the slightest touch or perceive it as an attack and lash out. They may refuse to eat certain foods because of the texture, where they might refuse to wear certain clothes because it doesn't feel good, like those tags in the back might bother them. Conversely, they may hurt themselves because they don't feel pain, such as when they touch a hot stove. They may dress inappropriately for the weather because they don't feel cold. Again, persons with sensory integration might be clumsy. They have problems kind of sensing where they are in space and bump into people or other objects. But on the other hand, they could also be extremely coordinated. That may not be where their problems are. And some of these on the slide here talk about the other sensory difficulties for an individual. So again, you have to think about some of these things in the context. If a person is having these issues, it's going to affect their ability to interact with others, maybe to hold a job or listen in a classroom, pay attention. If things are really bothering them, if you're in a classroom with, high fluorescent lights, overstimulating walls with artwork and, maps and pictures, they're not going to be able to, process information, and they're going to shut down, or they're going to act out in inappropriate behaviors. So what we really need to do is to modify the environment, really to simplify the environment. Individuals with FASD do much better with simpler, more consistent environments where they're likely not to become overstimulated by lots of objects. They also do better often when there's a physical presence by a person, one-to-one, who's physically with them, maybe to help them filter out those distractions and stay focused and safe. There may be some sensory triggers. Individuals with an FASD may have problems with certain food, clothing, strong odors, all sorts of stimuli. So again, you want to avoid the stimuli, that may trigger these negative reactions. Remove those tags from the clothes if they're bothering you. Or you don't go to the amusement park, on the holiday weekends when it's more crowded. So these are just, again, some examples, but, again, really need to remember to keep telling you and keep reminding you that individuals with FASD are very different from others. So some individuals may not have these sensory issues. Others might, it might be more of something else that might be more of a weakness for them. Now, the CDC does have really good information on what we might call more traditional treatments. We just didn't have enough time to really cover all of that today. But they do have a lot of good information about medications, whether we're talking stimulants or antidepressants, anti-anxiety medication that can often work for individuals with FAS. They have information on different behavioral and education therapies. There are evidence-based practices that look specifically, let's say one example might be specialized math tutoring, friendship training. There's some information on parenting, behavior management training, parent-child interaction therapy. These are different evidence-based interventions that the CDC has funded over the years, and some of them work in classroom environments, some work in workplace settings, some are to be dealt with in the home environment. So you can do a lot of research on that. They also have information on parent training as well, and also this whole area of alternative approaches. We find that some families and individuals are experiencing benefits of approaches such as biofeedback, acupuncture, animal-assisted therapy. There's been a couple of articles lately. I know there was an article in the New York Times. It was called simply Wonder Dog, and it was about a family that has been successful in using, a dog for therapeutic purposes. Now, very often, a lot of this animal-assisted therapy is very expensive, or it's not available in all communities. So I do want to bring your attention to information on the CDC website. So I just wanted to put this slide in. You could really do a webinar of 2 hours alone just talking about some of these interventions, but this is a brochure that I found on the web that is it kind of summarizes things that are very helpful for individuals with FASD in terms of looking at some of the executive functioning, information processing, behavioral weaknesses, that these are kind of practical things one can do. This is a nice handout if you want to give it to a teacher or to a caregiver or medical professional. But these are kind of tips that have been found to be helpful with individuals with FASD in terms of the brain damage, the problems that they face due to that prenatal alcohol exposure, the need for simplicity, for routines, for repetition and structure and supervision. For many people, a parent might say, it's, I'm the effective intervention. I'm the person who kind of is their Jiminy Cricket that sits on their shoulder, that translates information for them, helps them process, reminds them, and it may be something that they have to do every single day because, again, of the problems that the alcohol has caused to the brain, that an individual might learn something one day and forget it the next day, so that they need that kind of an external brain to help them along. So I want to just spend about 5 minutes whipping through these resources, so then we have time for more questions. So the first is a link to our agency website, and you can actually link all the other, these sites can all be found on our website as well. So in other words, the SAMHSA, CDC, NoFast, FastLink, and ACOG can all be found on our web pages. We do have special web pages for FAS, and we also have, as I mentioned, SFIR. The addiction medicine also talks about other drugs. So there's really 3 different places to find information on our website. The next is a DVD that's available actually online as well on the SAMHSA YouTube channel. And this is a great message because it's really talking with birth mothers, but it's talking about how they become warrior moms to kind of move away from the guilt and shame of having caused this to their child, but to become very strong advocates for their children. And the DVD is actually broken down into 2 half-hour parts, but on the website you can look at it, in chapters. So for instance, there's a whole chapter about how early intervention services can help young children. There is a facilitator's discussion guide and client brochures. However, the last time we checked online, the video was out of print. So you have to really look at it online on the website. And it is available also in closed captioning. The next is a toolkit that was developed by the American Congress of Obstetricians and Gynecologists. They've actually revamped their website, but this information is still out there. And it's actually, the clinician tools are very good because they do talk about how to have that conversation with your patient, and they do have copies there of the standardized drink size. So these are some very good clinician materials. And I didn't mention before, but Grace Chang is kind of the guru in the field of alcohol screening. She's based in Boston, Massachusetts. And these are some articles that have talk about how to do screening. And again, screening can be done in so many different settings. The brochures are also downloadable. The Helping Patients Who Drink Too Much Ignore where it says see next slide, because I already popped those slides in. So Chris, I'm going to open it up for questions. Sorry I didn't leave more time. There's just really a lot of material when we do this webinar. Usually we allow for 3 hours actually, so try to cram a lot of information in, and I'd be glad to open it up for questions.
Okay, I have 2 comments here, and I just want to note that we will have your slides emailed to all the attendees, so they will be able to review, write down any links that they might not have gotten to. So we will have that available for them. Okay, let's see. I've got 2 comments and a question now. Okay, most of these therapies that you talked about are extremely expensive and have not been disseminated to the general public from the clinic setting. Most insurance companies do not cover these therapies. And another comment is...
Let me just, just before you get onto that one, well, my only comment in response would be that's why I kind of concentrated on sensory integration, although I didn't spend a lot of time on that. But some of those techniques can be used, for instance, in the classroom in terms of modifying and simplifying the environment at very little cost. I mean, it might be having a beanbag chair for a kind of self-soothing environment. Again, modifying what's on the walls and the lighting. And we've also found that, as I said, these techniques are from the autism community, and in fact, some of these techniques will help all the children in the classroom, not just those with FAS. But I agree there is an expense to some of the other interventions, and probably it's because it's not out there, in the mainstream. It's still seen as very kind of individualistic in where it's offered, so it's not widely available.
Right. Another comment is that secondary disabilities occur when the primary disability, brain damage, is not addressed from the beginning.
Right. Yep. Right. I believe I said that, so it's worth saying again.
And then, let's see. Oh, somebody once says here that this presentation is very beneficial, and the attendee also was in part 1 and have used the information from that webinar as a reference several times. So,
good to know.
And then here's another comment. Providing one-to-one supervision is known by families to be one of the most effective forms of preventing behavioral issues. This intervention is extremely stressful to families, and care needs to be given to families to provide respite, experience child care, and having the most up-to-date information for the families as possible.
Right. Right.
And,
yeah, we talk about respite a lot in our trainings because that is something that families need, and there usually is not enough funded respite available. And the other thing about child care is that a lot of these individuals will need very specialized child care arrangements, which often aren't available because they are, considered children with special needs. So it's not always going to be available in every community, but that is a very important support service for families.
Here's a question. Do you have any advice for a lawyer in navigating the criminal justice system with a client with FASD?
Okay, that's a really good question, and I would probably direct you to there is information on our website. It's a link, but if you Google the University of Washington and probably just put FASD and legal, because they actually have a law clinic there, and they have a lot of journal articles, and they've been tracking a lot of the court cases that have been happening around the country for individuals with FASD who have been charged, in different criminal incidents. This is an area that has actually gotten a lot more attention recently in Canada, and I believe last week it was, the state of Alaska actually passed legislation. I don't believe it's been signed by the governor yet, but really within the last 7 days they have passed legislation that would permit more information about FASD to be used in the criminal setting. So this is a really important area because involvement with the criminal justice system is one of those secondary disabilities. And we don't have very good statistics or research, but most people seem to think that a lot of individuals in our juvenile justice system do have, undiagnosed FAS or FASD. And it's the prenatal alcohol exposure really that has brought them to that situation. So there are a number of experts. David Bolden, if you Google him, Bouldin, Tony Warnick, and I don't know the spelling of his name. He is out on the West Coast. David Bolden, I think, is in Canada. I know we have some articles on FASD and the criminal justice system on our website. There are also some fact sheets from the FASD Center for Excellence that talk about FASD for criminal justice professionals. We used to have a woman in New York City who was an attorney in private practice that was doing pro bono work training lawyers from the Legal Aid Society in New York City. Unfortunately, she's moved out of state. But this is an area, if you do Google University of Washington FASD, you'll find some articles because we are finding that there is more acknowledgement and awareness that FASD needs to be seen as a factor with some of these individuals who are involved with the criminal justice system.
I just got one more question. If a mother denies consuming alcohol while carrying the child, can the diagnosis still be given?
Well, let's see. I assume this is a diagnosis for, after birth. So the child's already been born and is going for a diagnosis, and the birth mother won't acknowledge it. As I said, the CDC will allow for an FAS diagnosis to be made if you only suspect it, but it's not confirmed. But a lot of people who do make the diagnoses are reluctant to do so without the confirmed information. Because one thing should be noted that FAS does look like other developmental disabilities. In fact, some of the facial features of FAS do mimic other syndromes, other developmental disabilities. So some diagnosticians do like to have more information on the mother's alcohol history before saying it's FAS. Again, because there is so much stigma. There's some people that don't want their children to be labeled this way and are reluctant to even go for the diagnosis. So it is possible, but it really depends, on all the other information that you can present to the people who are involved with making a diagnosis. Because there should be a huge, thorough, comprehensive history and assessment, of the child that should go into that. That may not be possible if you're dealing with, a very young baby. I mean, you're not going to be able to do some of the developmental tests, on an 18-month-old that you would be able to do on a 3-year-old or a 5-year-old or a 7-year-old.
Okay. Okay, I think that's it. I'm going to take the screen back just so we see my final screen. And thank you, everybody, for attending. Before the end of the day tomorrow, you will get an email from me that will have the certificate of attendance, a CEU order form, the PowerPoints from today, and also the evaluation, which is very, very important for us to get. So we hope that you all click on the link for the brief 2-minute survey. And then sometime next week, hopefully early next week, this webinar will also be available online, where you can also view session 1 if you'd like to see that. And that's at the website noted on the screen, www.ireta.org/webinars. You'll also be able to register for upcoming sessions too. Thank you very much, Margo. It was just as interesting as the first one. And at this time, we will say goodbye, and I will close the webinar. Thank you all for